Hello my dear friends, this video is about a few questions which is put by one of my viewer, and he has sent me messages on Instagram, and this question is about endodontics and the difficulties what he is currently facing. He is from Kashmir, and I'm glad to receive such important questions. The first question what he has mentioned is the awareness for dental treatment is very less in that area. Now I know it can be disheartening, but you have to remember that everybody thinks about doing treatment, but the most important thing in your clinical practice would be educating the patient, because if you get disheartened and you don't educate the patient, then they will not have they will not develop awareness. You educate, you create awareness for one patient, whoever comes to your clinic, they will go and educate another 10 patients, and this is how you build your client. So that is very important. Second question what he asked me is about the post-operative pain, which happens in many cases where he has observed it, that it commonly happens in his practice. Based on my experience, I used to get a lot of post-operative pain when in my patients when I was doing my post-graduation, especially initial days when we are supposed to do with hand instrument. So whenever you do rotary with endodontics with hand instrument, you tend to don't have the crown down technique. It is more of a step back and learning. You don't know how gentle you should be when you are using the instruments, even K file when you are using. So what happens is you tend to push more of debris outside the foramen. So this clearly ends up having that flare up and even swelling in some patients, and this is really, I know it is stressful to see that. So my advice for you, if you are doing this, because I don't know whether you are doing rotary or hand instruments, if you are doing that, preferably have shift to rotary, use more of a crown down technique, and that can definitely help you to overcome this situation. And irrigate really well. If you nicely irrigate with saline, hypochlorite, even with saline, if you irrigate a lot, then trust me, the results, post operative pain results do reduce. Of course, the third question what he has asked me is that should I do remove the pulp tissue in the first appointment or second appointment. Trust me, given an option, the best way to do root canal treatment in majority of cases is the first appointment. But that requires skill, because single sitting you have to be very sure that you have removed all the pulp tissue. You should be able to overcome the difficulties in a very short period of time. And this comes with practice, and you have to do cases to develop confidence to do such single sitting. If you don't do it, you will not develop confidence for single sittings. So there, given an option, I would like to inject in first appointment and do biomechanical preparation, because second appointment patients in between, because you have removed all the pulp tissue, the patient will be very comfortable. And in next appointment, sometimes you can you don't have any pain in the patient. Now this is very important, so you can do that. After that, he has asked me that in second appointment, sometimes even though you have done BMP in first appointment, sometimes you have pain in the second appointment. Now here, this is very important to understand, because see, many times I have seen that in second appointments, patient do not give injection or anesthesia to the patient, and because they believe that in first appointment I have given injection and I have removed the pulp tissue. See, that we really don't know whether complete tissue is removed in first appointment. So many times what happens is practitioners, suppose the working length was 19 millimeter initially and you have done BMP 19 millimeter, but in second appointment you have not given any injection, and then you put this 19 millimeter any GP and patient has pain. Now what happens is, even though on X-ray it looks short, but because patient has pain, people will under obturate. Now what they think, maybe by under obturating I am doing right thing, but this is wrong, because what ideally you should be doing is that you have to respect that working length, and if pain is there, you should inject the patient and then obturate by doing BMP again, because second appointment pain at working length, proper working length only indicates that there is a pulp tissue. That's very important. So third question what he asked me is that suppose I am not sure the pulp tissue is removed, can I put calcium hydroxide and does it benefit? Calcium hydroxide as such doesn't remove the pulp tissue. I don't think that, because it is more of a irrigant, especially hypochlorite, which has this dissolving property, or your instrument has to make sure that pulp tissue is removed along with the irrigation, and that can happen only when you actually meet the preparation size of, you have to see what is the canal width and you have to match that. Unless that happens, you will have tendency for the pulp tissue remnants. So I will not simply put calcium hydroxide because I have pulpal remnants. I would like to still continue with proper biomechanical preparation, and if I see that patient has swelling, patient had a large periapical lesion, and preoperative pain, acute pain, in these situations calcium hydroxide is really beneficial. I personally don't use lot of calcium hydroxide because over the period of I realized that if you are done nice cleaning and shaping, calcium hydroxide is really not needed, but your irrigation protocol has to be really good. But although the textbooks do say that canal should not be left empty, it is always preferable to put calcium hydroxide, and you can do that. But the calcium hydroxide, when you put, it should not be like it is just there in occlusal 1/3. Then the benefit is very less. It has to reach the proper length, at least 1 or 2 millimeters near the apical terminus. The next question what he has asked me is how long I should leave calcium hydroxide. Now this is very important. The most important thing to remember is that if you go back and see the literature, the calcium hydroxide's effect, maximum effect, generally tends to start after 7 days. So if you have put calcium hydroxide and you just remove it within 2-3 days, then the effect was not because of calcium hydroxide. It is mostly, it may be like not putting calcium hydroxide would have been also equally acceptable in this situation. So water based one should be preferably used, and that tend to have effect till 15 days if it is water based. If you have an oil based one, which you are not supposed to use in any situation because it is difficult to remove, you can leave it for longer duration, sometimes for 1 month and all. Some cases take a lot of time to resolve, so that can be done. So these are in general my question, my answers to your questions, and I hope that this is helpful to you. If you have any further questions, please mention in the comment section and I will definitely answer it. Bye for now.